We're live, Commissioner. Yes, we're ready. Yes.
Welcome everybody to our Finance and Planning Committee meeting. For those who think that they are here for the budget hearings, this is not the meeting. This is a meeting to go over contracts that the department is proposing for acceptance by the Health Commission. Would our secretary please call the roll?
Sure, I'll start with you, Commissioner Chow,
Present?
Commissioner Guillermo,
Present.
and Commissioner Dorado.
Present.
All right, I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. We can move on to item 2, which is the approval of the January 5th, 2026 meeting minutes.
Commissioners, the minutes are before you for acceptance. A motion is in order.
Move to approve. Second.
And is there any public comment on the minutes? No comments. So all those in
There's no
favor?
line. Okay, all those in favor, please say aye.
Aye.
All right, thank you. Item 3 is general public comment. This would mean making comment on items that are not on the agenda. Does anyone in the room like to make comment? See no hands. There's no one who's gotten remote permission, so we can move on to, actually, I have the wrong agenda in my hand. We can move on to the,
Should be the January.
yes, the January
report.
2026 monthly contracts report.
Hello, good afternoon, Commissioners. Michelle Ruggles, Director of the DPH Business Office. Maybe you know that Kim Baker, our Contracts Office Director, resigned and went back to Palm Springs, where it's warmer. So anyway, here I am today to present January and February to you. We've kept them as separate packets. Hopefully that makes it easier. So you have a cover memo. Originally, there was 5 contracts, and then it moved to 4, and the 4 contracts are listed here. And as of today, we're also, the DPH leadership has requested pulling Facente and moving it to the next month. So what you have is Baker Places, 2 Baker Places, and then the CSI Companies, Inc. And it's possible if you have Rafiki in your packet of information, that was just a misprint. That was the one that was pulled. So just ignore that one altogether. It's not posted in the calendar. So the 3 contracts before you today that will be presented today are Baker Places, which is Ferguson House, Baker Places, their supportive living program, and the CSI Companies, Inc. So.
Well, actually, before you begin, Commissioners, I'm thinking about time today. Would you like Ms. Ruggles to go through all the January contracts? I know you all already asked questions on this, and I'm just, again, thinking of time, but if you want to go through your full process, do whatever makes sense to you.
I think because the number is manageable that we should do so. And Commissioner Dorado just arrived on our
Yes.
committee, so I'd like her to have the opportunity
All right, thank you.
to hear it.
Thank you.
Okay. So then the first contract today is Baker Places. It's Ferguson House. It's requesting, I should say that all 3 of these are new contracts that are continuing existing services. What's changed in Ferguson House, the first one, is that they have since become Medi-Cal certified, which means that we'll be able to bill for reimbursement for Medi-Cal. And in so doing, I think the program is a 90-day mental health transitional treatment program. And so that will allow more churn, which will allow, I don't know if that's the right word, and the program person can jump in, but that's why the total number of beds increased, and that's the number of, I think, slot capacity. So we moved this contract. It was a combined contract, and you'll get to hear about the other one as well. But we've moved it onto the DPH bed ordinance. So because it's a new solicitation authority, it's also a new contract. So that's why this one has come back today. And I don't think on this one you had any questions,
Commissioners,
but
question?
if you do, I'm here.
Any questions on this?
Can I just want to confirm, then with the new funding, it'll be a total of 92 beds?
I'm going to let Ametrio Garcia speak to that. I believe it's still 12 beds, but it's the number of people, but I might be wrong. Is
Okay.
he on to confirm?
Yes, he's unmuted. Can you answer that question, Emma?
Emma, if you are there, the question is to clarify exactly what this means. I believe that Ferguson is 12 beds, but it says previously with 80 beds and now a total of 92 beds. And I believe that is actually the increase of people that you can see. But are you able to confirm what that means?
Sorry, commissioners, there must be a technical issue on that. Oh, on that end. We will try to get that information to you during the meeting. I'll email him.
Okay, thank you.
Apologize.
I'm sorry.
Any further questions? We'll wait for, oh, somebody's coming.
No, that's a different person.
No?
Hey, Jeff, can you get off camera, please, until you're speaking? Thank you. All right. Any other
Sure.
questions on that particular?
If not, let's go on to the next contract.
Okay. Next contract is another contract with Baker Places. It was combined also in a single contract, and it has been separated out again. Same reason we're changing to have it captured under the bed ordinance, and also separating because it's different sections and behavioral health services that will oversee it. So this is a continuing program that provides services to people that are living in, I think it's 36 scattered sites around San Francisco. So the idea is to provide similarly like a supportive housing day to maintain the stability of the individuals living in the supportive housing or co-op site. And then the second, much smaller portion of this contract is for rental subsidies that people can apply to if they don't want to live in a congregate housing and need funding to support a more independent living environment. And if you have program questions, I believe Kelly Hom is here.
So I guess, I don't mean to keep asking questions, but in this document for rental subsidy days, it says 8 clients. And then when I asked again, in this written documentation, it says 6 clients. I'm just wondering, which is it,
Why the
6 or 8?
You
This
mean
was-
6 or 8 clients funded through this contract?
Pardon me? The contract here says 8, and the response to the questions
Says
says 6. So
I'm sorry, which question number was that?
that
That was last
question
month, right?
was
Last month's.
4.
response.
It's page
Page
4
Page 4.
of the
Other
of the
responses.
January 5th
Right.
document. Do you have that?
No.
Is that
It's not the new responses, it's the responses from last
This
month.
is
This is the last time.
the last responses. the
Sorry, I
January
didn't
5th.
print out because I wasn't involved in January. Do you have?
Well, I think the question.
Right.
is fairly
So,
simple, 6 or 8, and while you're mulling that over, could you
Yes.
tell me how somebody becomes eligible for rental subsidies? I mean,
I think they go through an application process, but maybe is Kelly Hom available?
Hold on, I'll move Ryan over. Ryan, can you answer that question? I just moved you over as a panelist. The question is, how does someone become eligible for or gain access to rental subsidies? Is that correct, Dr. Chow?
yes.
Hi, good afternoon. Can folks hear me?
Yes, loud and clear.
Hi, this is Ryan Fuimon. I'm a program manager for behavioral health services, substance use services. Yes, Michelle was right. Clients of the B-Slip scattered site co-op housing have the opportunity to apply for the rental subsidy as kind of like a step down next progression in their continuum of care. And going back to the question of 6, not 8 beds, 8 is the total number of contracted unduplicated clients in the contract. But when we looked at actuals to respond to the question, we saw that 6 clients had been served for the time period. But 8 remains the contracted UDC goal.
Is that
Okay,
satisfied?
thank you.
I'm still not sure I understand exactly. You have 36 clients. What is it that certain clients can get $14.81 per day and others don't?
The 36 clients are the ones at the scattered sites, and they have the opportunity after staying for some time, and I'm not quite sure the length of time, to apply for the rental subsidy, which allows them to live in a more independent setting.
Oh, then they go somewhere else with the subsidy?
That's right. They're just receiving a rental subsidy to
Oh.
live independent in their own apartment or in a shared apartment, but not in the co-op site
Oh, I
managed by
see.
the
So they're
program.
leaving the co-op site and they're getting a
That's right.
subsidy to go elsewhere. Okay,
That's right.
all right. So actually, getting the rental subsidy equals success.
Yes.
Right.
Okay, thank you very much.
Thank you.
We'll then move on to our next contract, Michelle.
Sorry, the pages, okay. Okay, so this also is a continuing contract. This is the approval, but it's a new contract for continuing services with the CSI companies that was previously solicited and authorized under the sourcing event that's identified here. This is being presented because of the new, there was a new sourcing event. They were reselected, and that is why this has become a new contract to present to you today. They provide what's called Epic Go Live at the Elbow support services for behavioral health services staff as they transition from their legacy electronic health record system, often referred to as Avatar, into Epic. And I will refer you to the Jeff Scarafia if you have questions on the program.
Yeah. Questions on this? Any questions? There are no questions, and this is a separate item, so we
Yes.
have to ask for a motion to recommend to the commission the acceptance of this part of the contracts report.
I recommend, move to recommend approval to the full commission.
Okay, our January portion here. Is there a second?
Second,
All those in favor?
aye.
All right, thank you so much. We can move on to item 3, February 2026 monthly contracts report.
Great, thank you. Okay. Okay, so today, now, is the February 2nd report, of which there's 8 contracts on the report. And you have them listed on the table, which the contracts are and the kind of generic reason why they're here. But let me just jump to the report itself, the report. So the first contract is called, or we call HR 360 SVIP. And this is a contract that we're adding annual funding to complete this term. And you had asked a couple of questions about that. One of the questions was, who's taking over this contract? And the department continues to work with the mayor's office and other city departments about that. But, and as soon as we know, we'll come back with that information and let you, the Health Commission, know where this contract has gone or is going. The bereavement fund is a little bit broader than bereavement, and it's broader than this program, the SFVIP program. And for that reason, we're keeping the program because I lost my, because it's managed inside of Behavioral Health Services Comp Crisis Clinic. And so they use the funding in that to address multiple needs. And so it makes more sense, and it's broader than the charge of SFVIP program, even when it's reallocated to another city department. The items that are covered through this bereavement fund will remain under the management of the Comp Crisis Clinic, who meets with the clients, meets with the families following tragedies or following a crisis to address their needs. And so this allows a quick, immediate response to those type of needs. And so that's why it's staying in Department of Public Health.
Okay, commissioners, questions, Commissioner.
Thanks, Michelle. Can you just repeat what you said about why it's remaining with DPH, even though another city department will be? So DPH is going to provide oversight on the funds, but another city department is going to manage the program?
Sorry, confusing. There's actually 2 programs in that contract. One is SFVIP, Violence Intervention Program, which is community ambassadors that go out following violence or try to prevent further violence escalation. And then separately over time years ago, we added bereavement funding into the same contract under HR 360. But the management of that program is Behavioral Health Comp Crisis. And so when the SFVIP transfers, there still may be people that are helped through that fund, but the fund that will remain under behavioral health is broader than just the people that are in this program, if that makes sense. So they may be working comprehensive crisis clinic. They may be working with victims of violence and their families. That may be part of like who gets served and follow up by DPH. And so they may receive funding that way. But there's also temporary hotels, funeral services. There's all kinds of related items that have been covered. And so just for efficiency and because the scope is broader and it's a tool that's very valuable to the comprehensive crisis clinic to be able to quickly address the crisis needs of these families. It's more direct to retain it in behavioral health than to go to another city department or another contractor. So that's why they didn't start as the same program. They're just 2 programs in the same contract. So it's really commenting. One is going away and one is staying.
So when the other, the part that's going away, will it take the budget with it or?
It will take its budget for SFVIP. The budget for bereavement will stay with DPH.
So is the part that's going with SVIP, the budget, is it not, it's not included in the upcoming budget then, right?
That's a great question. I think that it would be, I don't know, technically if it's included. It's not anticipated to continue. I don't know if physically they've transferred it because I'm not sure they know where to transfer the funding, but it's not DPH funding that will reprogram for something else, if that was what you meant.
If we could just get a quick update, then when the decision is made, what city department and what budget will be moving, if at all,
Yeah,
at some point.
it will
when
be moving, but yes, I'll find out if it's in the current proposed 26-27 budget.
If I can quickly do a 1 minute, my understanding is 2015, this came to Barbara Garcia from Mayor Lee. It wasn't being handled with whatever department it was being done well. Barbara kind of convinced Health Right 360 to take it on. And it really kind of didn't belong there, but it's taken quite a while to figure out where to go to. The DPH is in contact with the current mayor's office to try to figure out where to go to. So this, it doesn't change your question by when, there's like a kind of a quagmire around, like, and a slow process, but I will
10
make sure.
years slow process.
Yes, I will make sure that you all get updated.
Thank you.
In the same line, so what the amount here in the proposed annual amount is probably not accurate, correct? Because we don't know about SFSVIP right now, if the funds are included in this contract, or if it's, then what you're saying is it's going to come down to just the programs under the bereavement program that will be funded.
Yeah,
Right?
so right, yes. Right, what you're looking at today is simply extending the contract through this fiscal year, May 17th, not even June 30th. So all the money that's represented here is correct for like the current contract. We're extending it because it's taken longer to figure out where it's going. But when the bereavement funds gets moved somewhere else in DPH, you'll either hear about it because you've asked and we can come back and say that, or you'll certainly hear about it when it comes back as part of a new contract, because we have to find a place now to continue the bereavement funding when this contract goes away May 17th.
So, Commissioner Gerardo, does that make sense? I know you're new. I'm going to make sure that we're answering your questions.
I just want to make sure, because I have people who use the Victims of Violence Fund, and that will continue to be under and included in the bereavement program. Am I correct?
I do not know the term of what the funds are, if they've labeled them under the bereavement fund. I just know it at that highest level.
I thought you
The-
had said that was part of it. So I just.
The SFVIP program, Violence Intervention Program, with all the staffing is moving away from DPH. The fund
Mhm.
that we call bereavement fund will continue to stay in DPH.
Right. Yeah, no, I understand that, but I'm wondering if in fact the Victims of Violence is part of what you had mentioned, was it is part of the bereavement fund, or is it part of the other? Because it's a well-known and well-used program.
Yeah. Is there someone on the program side who should, I don't know who that person is, but who could answer?
I don't know if Stephanie Felder, Navina Babaran.
I don't see it.
But because this says it supports burials and associated costs for victims of violence. So I'm just clarifying that.
It will continue to do the same thing that it's doing, yeah.
Okay. Okay, that's,
Through the extension that they're asked to approve.
Everything that's in the current piece of paper going through May, no change, except the
Okay.
date. And when
May.
it changes, DPH will continue the bereavement funding program. And that includes, there's a little more detail maybe in the
Right.
most updated, the response you would have gotten today, the February contracts report. And it's for victims of violence, their families, and community with specific services. So there's other things in addition, but it will still cover, I believe, everything that's being covered right now.
I realize this doesn't give you clarity. I think the question being, what is in the bereavement fund?
Right.
That will remain, but the way that I read this contract as it is, you are proposing basically about a 5-6 month extension of the total contract
Right.
To May.
while waiting for it to separate.
Hey, this is more.
So perhaps for information for Commissioner Gerardo, we need to provide what is in the bereavement fund, but that's sort of in the future what remains. But this contract will allow it to continue as it is
Okay.
to mid-May.
I don't know. But I'm in a meeting right now, so I gotta go.
No, I saw that. Yeah, I read that. But it wasn't,
Yeah, it's not totally clear because the write-up talks more about burials in the matrix, and your response leaves it somewhat unclear what else is being incorporated in a bereavement fund. But I think that for the purposes of today's contract, the
Well, this-
question is
okay.
extending the current situation through mid-May
and then,
while they straighten out and
Who
we
does what?
probably then would need to get an update as to what is going to remain under bereavement.
come back for a new contract.
Right.
Right. Is that correct?
What's in this paragraph, we can line item it and like extrapolate on the definition of like what funeral services includes. So you can see.
Yeah, it's sort of important to understand
Yeah.
which way it's going to separate out. But
Yeah.
again, for right now, point is that they want to extend this contract so they can work on this and give us that information as we go along. Okay.
Okey doke.
All right. Any other questions on this particular question? No. All right, let's go on to the next one.
Okay, so the next contract is a UC contract for Veggies for Vouchers, EAT-SF program. There is no change in scope. What's changed, well, the term has been changed. They're ahead of their game, extending it by 2 years now to make it a 5-year contract before it expires June 30th, 26. And then the annual difference is the CODB.
Could you, since Commissioner Dorado is new, what is CODB?
Sorry, cost of doing business increase.
Yeah. And my other question is for the programs. I know it goes through WIC and, BIH, but I'm wondering, since we have a lot of WIC clients, exactly, is it distributed then for those that sign up and their goes back on their debit card, or is it, how do families within those programs are aware of the ESF program, and where does it all happen?
Okay, I will switch. Is Pretty on here? Okay.
Yeah, I can speak to that. Thank you, commissioners, for that question. So for WIC, it's automatic enrollment. So all of our 1,200, we enroll around 1,400 to 1,600 pregnant participants annually, and it's an automatic enrollment. So once they enroll into WIC, they get automatically enrolled into EAT-SF unless they specifically say they do not want to participate, and the vouchers get mailed to them. We're still working on the vouchers, and it's a different card than the WIC card. And for the BIH families, it's very similar. Once you're part of the BIH program, this is an automatic enrollment, and you receive vouchers monthly as well.
Okay, that was my question, is, where, how?
Warehouse.
Yeah,
Okay.
it just,
Thank you.
Right.
I always like to know. the logistics for some of our families.
Okay, thank you for clarifying that. Let's move on to our next contract then.
Okay, the next contract is with the Public Health Foundation Enterprises that we often refer to as Haluna Health. It's an amendment, no change in scope, no term extension, but it is a change in the service level funding, i.e. annual funding is going up. This is a contract that provides funding and operational support for, in the longhand, the Brief Longitudinal Incident Sentinel Surveillance Project, and in shorthand referred to as BLISS. And it's a public health initiative that collects data on people who inject drugs in Alameda and San Francisco counties. So I think you had a couple of questions and that were answered in the February report. Like a lot of, ran out of stick. Okay.
Teachers'
Yeah.
questions?
Yeah, it worked.
Oh,
And the program representative, Mr. McFarland, is on the line.
Any other questions, commissioners?
any other questions? I was happy to hear from the response that these are contracts already awarded by the federal government. So,
Yeah, no, and I thought the answer was, I really appreciated that, I guess until the close of the contract, oftentimes the information on the data isn't available. And I just wanted to confirm it's not going to be available until the
Yeah,
end of the contract. I'm just,
I read the same thing, so I'll let the
okay.
program confirm.
Oh,
Hi, is that for me to chime in?
Yeah, please.
Hi, this
about the
is Gordon
data.
McFarland. Actually, we generate a lot of information as we go. We already have some reports and publications we've presented back to the community groups we work with on, for example, on the baseline of the cohort that we assembled in Oakland and San Francisco. So at any given moment, we're analyzing the data. So we don't have to wait until the end of the study to learn from it. Another example is the supplemental CDC funding to estimate the number of people who inject drugs and hepatitis C prevalence. That should be available sometime later this year.
any further follow-up? Or,
No, I think that, I mean, that's really helpful, but I guess it would help me just in the future. Let's say with the data from the BLISS cohort, just even for our further understanding too, is you might give a one-liner or two lines of something about your data so that we're not looking at things always in the abstract, but it helps us to further understand.
That's an excellent idea. I love data personally. I was worried I would overwhelm you with too much, but I'm delighted to actually work in a few lines of some of the more interesting findings we're finding as we go. I was also, I think in the response I offered that when we do our branch updates to the Health Commission, we can give a focus on what we've learned so far from these data.
That's great. I'd appreciate it. And I'm kind of a data focused person. So you and I are in the same boat. So that's what I would appreciate. Thank you.
Great. Love to. Thanks.
I think we can all echo Commissioner Gerardo's desire for more information, whether it be baseline that helps tell us how this and our other contracts are performing, and also outcomes as we're looking at renewals. Yeah, so I know Michelle knows that. Thank you. Let's proceed to our next contract, please.
Okay, the next contract is 314E Corporation. This is an amendment that reflects an annual increase to this contract, bringing the total not to exceed amount up to $5 million. The reason for the requested increase is to provide the EPIC Phase 3 support, and specifically this is for support during the rollout, again, part of CalAIM, but the rollout of substance abuse services moving from reporting in Avatar to reporting in Epic. And I will refer any more detailed questions to the program or Jeff Scrofia.
Commissioners, any questions? It's rather amazing to note all the different EPIC programs there are. And so it isn't a simple system, obviously.
No.
So
Just one quick question. So the increase in funding, is that mostly come from the grant funding or is it mostly general fund?
That is correct. It's primarily grant funding, almost entirely.
Thank you.
Any other? There are no other questions on this, then we'll move on to our next item. Our next contract.
Okay. This contract is with the San Francisco Public Health Foundation. You'll notice it starts January 1st, 2026, so slightly retroactive. But what we're doing is we have ended the contract with the HR 360, who had this contract for 20 years. And in this latest rebidding, they opted not to apply. And fortunately for us, the San Francisco Public Health Foundation did. So what they're doing is continuing a long-term existing program that is a program administration contract that directly supports civil service programs. This is somewhat of an older model that we don't use the same way as we did 25 years ago, but there's still some legacy and some benefit to, well, there's still a lot of benefit to continuing the services, but of the 7 programs, 2 will be ending June 30th, 2026. But you can see down in the service description what is in here for examples. But the idea was when this started is that it was services that would support our programs in behavioral health services that, and this is a little bit broader, MCAH and jail health used it, that were difficult to provide through the civil service mechanisms. Over time, we have a lot more flexibility and ability. And so I don't anticipate after these 4 years that this actually will need to continue or even continue at this level. But so for example, right now, the Parent Training Institute is a program that's operated out of behavioral health services. It's a jointly funded, mostly funded from other city departments through work orders, but our BHS provides a coordinator for this program and then works with DCYF and Department of, you would know, and I'm forgetting, DEC, that has families, parents that enroll into this program. So the funding in that program, like we have DPH civil service staff overseeing it, but the funding's paying for the supplies, the training materials, the childcare. So it's sort of one-off type of support. But anyway, it's an important contract that we've maintained for years. It's gotten way smaller. And even between the prior annual amount and the proposed annual amount, it's a lot smaller because we've just narrowed down to everything that's essential that we need to keep in the contract. We needed to not end it December 31st. And so we'll go through 4 years and that's it, sir. That's it. Yeah.
Commissioner?
So with the previous vendor and now with this proposed vendor, were they all pass-through funds to other organizations, or did 360, Health Right 360 and San Francisco Health Foundation, are they directly managing the programmatic aspects of all these different things?
They're not managing, they're managing the, they're supporting us. So like if we're writing checks or if we need checks to pay childcare consultant, childcarers to provide childcare. So what they're doing is there's a few employee positions in here. So they're doing that HR management. There's some like the operating expenses for Black Infant Health grant. We, a few years ago, well, 2016, we moved a ton, like 78 people out of this contract into civil service positions. And so the Black Infant Health money right now, what's in here is operating expenses from that. I think of it as a grant, but it's the matching funds to Title 19, but whatever, it's the operating portion of the Black Infant Health program. And so slowly that will be brought in-house as they set up the receiving, for example, create a lease inside of, like, through the Department of Real Estate. Back in the day, like really back in the 20 years ago, we might have funded, like when managed care came over to San Francisco, the mental health plan, we had certain things that had to be started, like now it's called Behavioral Health Access Center. But because the managed care start date was what it was, everyone was funded through a contract. And that's how it started, because there wasn't time to get people hired. Nowadays, we have a lot more flexibility, or ability, I should say, to hire someone temporarily if it's a short-term project. And so this isn't the mechanism that Behavioral Health Services utilizes, but it's not passed through. It's in support of, it's our money. Some of it's work order funding, but it's money that comes to the Department of Public Health. It's in our budget, and we put it into this contract to support these program areas.
So in the future, the department will be able to, won't have to contract with an outside agency to
I
provide the operational.
Yeah, I think, yes, I think that that's the goal always now. There's still some things that are hard to do, that, like paying individuals who are providing childcare so that the parents and the Parent Training Institute can, complete the whole session and come every week or however long it is for 10 weeks. So things like that, we just have to figure out how to do that. Does it make sense to hire I don't know what, health worker? But so there's some things like that logistically, like what would it be? But generically, like before it was hard to buy client expenses. Now there's processes, gift cards, or there's just things that allow us to be more nimble that we did not have 20 years ago. So I think just looking at what's in the detail, most of it, if not all of it, can come in-house. But if it's what's left, I think it'll be a very much smaller amount in this particular contract.
Thank you.
Thank you.
But from what you're saying, it still goes through 2029.
Yeah,
So,
we,
so for the next few years, it's basically same as for the 3 BHS programs as well as the methadone ban.
yeah, so like for
Those
example,
four
the
things.
methadone ban, maybe we can set up a lease. Right now, we have a lease and I think it's at a church location. Can we set that up with civil service? It's just that kind of thing. We may not need the whole 4 years. I know MCAH, you can't see the out years in this. We budgeted the maximum, but they're anticipating already that they can, ratchet down each year. So we're aware of what all the line items are and the people and what the steps are, but now it's doing it, and it's come down like maybe, I don't know, at one point it was probably 20 million a year. So you can see it's already quite a bit less.
Yeah, I'm just, like Parent Training Institute, why doesn't DCYF figure it out? Instead of us contracting with the Public Health Foundation to,
Well, if I may jump in, I'm also concerned, a little concerned about time. With the budget constraints we're moving into, I think the DPH would be more creative in the solutions around this kind of thing. And as Ms. Ruggles said, when you all approve a contract, it doesn't mean that the contract will actually last that long. It depends, it's just that you are giving permission to expend the
Okay.
funds for that amount of time.
which is great. I'm just wondering in the future for the creativity, if it's somebody else's,
Sure.
let them do it.
Note that. Thank you.
Well, I think
Okay.
your point, well taken, and we've been always trying to see that the city employees perform the work that they
Mhm.
that we can have done here. So, so this is one in which actually we are moving towards that, rather than just being outside contractors. So, thank you.
Okay.
If
Sorry.
there are no further questions on this contract, we'll move on to our, I guess, the last of the contracts.
Okay. So the last contract is with Lutheran Social Services of Northern California. And so this request is to, oh, it's a new contract for continuing services. Sorry, I just read that. And so it will continue its rep payee services that it has been providing. And you can see a breakdown of what's included in the funding, but it's no real change to speak of. But I believe the program representative is online if you do have any questions specific to what you're reading.
Commissioners, questions?
No, I just want to thank whoever put the table together to answer the question of
Yes.
unduplicated clients.
Oh, right, because there's.
So I just want to say thank you.
Yes, they tracked that down this morning. That would have been Bill Bloom, I believe, or Beth Neri and Beth Neri.
The response is interesting in as much as
Mhm.
the contract calls for 425 unduplicated clients, but we're actually running somewhere between 200 and 300. So in that case, is this by the number of clients they actually have, or we just pay them the monthly sum, and if they take care of 425, that's what they were contracted here for, and if they pay and are taking care of 293,
Right.
then they still get the full amount?
I think they only get paid for the clients that are enrolled in the Rep Pay money management program, but are Bill Bloom or Beth?
Either both Beth and I are on. Would you like us to answer?
Yeah, please.
Yes, quickly.
Yeah, it is cost reimbursement, so it does primarily pay for salaries. What they have noticed over the years is that they have clients with much more intensive needs, so they amplify the number of units of services provided. But they don't maintain a waiting list, so they can expand to serve more clients if they are so referred, and they are doing a fair amount of outreach to increase the number of clients served.
Okay, it just sort of distorts the
Yes.
cost per hour,
Mhm.
but at least it's a cost reimbursement program. Okay. Question? All right. Then let's see, before we take the new contracts, we have to take up this on the consent
Yes.
calendar also. For the February contracts.
Move to recommend approval to the full commission.
Second.
All those in favor?
Aye.
Thank you
Thanks.
very much. We can move on to item 4, request for approval of agreement between Chess Health and DPH for contingency management.
Hello, Commissioners. My name is Emily Raganold. I'm the Acting Director of Population Behavioral Health within BHS of the Department of Public Health. And today I'm seeking approval for a retroactive contract agreement with Chess Health for a total of $1,445,920 for a term of 5 years. Chess Health will provide the county with an e-reward recovery module that will be used with 10 currently active contingency management programs in the city, with room to add 5 new programs during the course of this agreement. This software will be a central way for all DPH and DPH funded programs to track contingency management participants, their rewarded behaviors, and also track and audit incentives as well, which relieves a huge administrative burden for both us as the county and for the programs as well. Just a note on contingency management for folks that aren't familiar, it's one of our most effective evidence-based treatments for stimulant use disorder and has been shown effective at supporting retention for medications for opiate use disorder as well. So participants will be rewarded for behaviors such as a negative urine drug analysis or attending therapeutic groups. And they'll be rewarded through, you'll see a line item for a PEX gift card, which is essentially a debit card that is reloadable and replaceable. And so the incentive funds will be added to that debit card. And then just an overall note on the total contract amount is that Chess Health is charging the county $42,000 a year for the operation and maintenance of the software, as well as providing help desk support for programs and the county. And then a $25,000 upfront cost for building out these modules. The majority of this contract amount, about 75%, is the actual cost of the incentives that we are loading into the software. We're loading essentially enough incentives for all participants across all of our programs. And then each program will be able to draw down from that fund in order to distribute the incentives to their participants. Any questions that I might answer?
You say that you're allocating the drawdown, and thank you for the list of the 13 right now programs. But is this from a big pool, or are each of these agencies given a certain amount?
Each of these agencies are given a certain amount based on how many participants they anticipate enrolling and what their models look like. And each participant is capped at a total of $599 a year in incentives that they are able to earn.
Okay. Yes.
Then on an annual basis for the money that, or for the contingent management, do they then, are you requiring data on how many have actually used the cards? Are you,
So that's a good
data.
question. I don't know if that's actually available to us to see like how much of the cards were utilized. I know that we have folks from Chess Health on the line, either Shannon or Meredith. Maybe they would be able to answer the call or the question.
Yeah, I'm not even concerned about the amount. It's just how many people.
Actually end up using the debit cards. Yeah.
Just how many.
I'm imagining mostly everyone, but maybe Meredith could
you know,
clarify.
what are the roundabout figures? It's that within each program or within the programs are they expecting?
100%. We would anticipate everyone to use the debit cards and use the funds on them.
100% of what number?
Oh, of how many participants we anticipate?
That's what I'm asking.
Anywhere from, I think this last calendar year, we had about 300 participants, and we anticipate that number going up to 400 this year as we're launching some new programs. And then we hope to continue to grow contingency management over the course of the next 5 years.
No, I mean, it's extremely evidence-based, but I'm just wondering that the number of participants and if it continues to grow and for, that money, just how many are actually on board.
Yeah.
So I'm hoping that you're asking that data.
Yes, of course. And so one of the reasons why we also move forward with this software is that right now DPH does not have a tool to centrally collect information like this across all of our programs. And so now we as the county will have access to a dashboard where we can look at program data across all programs, and then each individual program will have access to their own participant data.
Great, as well as you.
Thank you.
Yeah.
Any other questions? If not, a motion to recommend this to the commission?
So move.
Second.
All those in favor?
Aye.
All right,
Aye.
thank you so much.
Thank you, commissioners.
We can move on to item 5, a request for a new participation agreement with Cal MHSA to perform third-party administration for the San Francisco County Department of Health.
Good afternoon, Health Commissioners. My name is Yoon Jung Kim, Director of Residential System of Care with the Behavioral Health Services. So I'm here to request for approval of a new participation agreement with CalMESA, which is a California Mental Health Service Authority to perform third-party administration for San Francisco County Department of Public Health in support of implementation of a CCE Community Care Expansion Preservation Grant, which is a state the funded initiative aimed at the preserving existing licensed adult and adult residential facility and then residential care facility for the elderly, which is also known as a board and care facility or assisted living facilities. So the total proposed contract amount is $7.8 million for the term of 3.5 years from the January 6, 2026 through the June 30, 2029. So the CalMESA will serve as a third-party administrator responsible for administration, disbursement, and the monitoring of San Francisco County's CCE Preservation Fund, which consists of two funding the grants. One of them is CIP, the Capital Infrastructure Project, and another one is Operational Subsidy Program. So CIP, Capital Infrastructure Project, funds for the essential physical repairs and safety upgrades to enhance the facility or and meet the licensing standards. And then OSP, Operational Subsidy Program, funds for to cover potential or the projected operational deficit, so to prevent closure of the facility and maintain services. So yeah, so the program support actually sustainability of boarding and care assisted living facility in the city and county of San Francisco, and then basically to support applicants of recipients of SSI or the CAPI, Cash Assistance Program for the immigrants. So including actually people experiencing homelessness or at risk of homelessness. So those people includes also medical beneficiary. So the scope of work of CalMESA is to perform related boarding and care eligible facility assessment and the selection process. So, and also for the capital project, and also the CalMESA expected to manage the disbursement of operational subsidies and CP capital project funds. And also, they are going to provide technical assistance on financial operations, capacity building from a financial consultant. So please let me know if you have any questions.
Commissioners and Commissioner.
What is the number of board and care facilities that you feel would be able to access these funds?
So roughly speaking, there are about 100 assisted living facilities in San Francisco. However, actually eligible facilities is the assisted living facility about actually the 30 or 40 actually facilities in the city. So the eligible facilities for CCE preservation is defined that they must have at least one SSI or CAPI recipient. And then so we actually reviewed all 30 to 40 the boarding and care facility with the Department of Social Services, which is a funder. And then we selected about 25, 26 candidates.
So it would be a total of how many altogether then?
So eligible facilities about 20, also the facility who showed interest about somewhere between, I would say 0 to 25, 26. We're going to actually host a meeting and then to survey and also provide questionnaires to select actually candidates. Yeah.
Okay.
Yes.
So this is a new program, correct?
Yes, correct.
So how will the DPH monitor CalMESA's administration of this fund across those potentially 30 facilities?
Yeah, this is a collaborative work between us and the CalMESA. So, and also Department of Social Services. So we're going to have like monthly actually, or more than actually monthly, weekly basis, kind of a touch base, and then to discuss actively who's eligible, who's actually, getting the award, and also having assessment evaluation. Yeah.
And does the DPH have any authority if things don't seem to be sort of being sort of administered as per how the DPH understands the grant?
Absolutely. Yeah. We have all authority. So CalMESA is just the third party administration. So, yeah.
It'd be helpful to have an update after the first year or so to see what issues are coming up.
Yeah.
And actually would also be interested in the kinds of issues that these ARFs and RCFEs are having in terms of being able to access the fund, what kinds of sort of difficulties, or if there are things that are needed from the subsidy that sort of appear more prominent than others, just sort of a general sense of what kinds of funds are needed for what purposes.
Yeah, so we are doing actually groundwork at this point, and then so approaching each actually eligible boarding and care facilities. I think they are still actually evaluating, assessing their financial abilities at this point, and then so in terms of actually the selection. The criteria, so we have a considerable actually discretion in selecting which facilities to award the CC funding. So including, we are going to actually review all multi factors, including like how much actually eligible expenses each facilities is using, and also what are the actually assets and also liabilities, and then also what's the solvency and also operating reserves and for each facility, and also any bills, any actually the payrolls or taxes more than 30 days overdue, and then so overdue. So, and also any kind of projection, what about the actually estimated annual increase in dollars? So all those kind of factors are going to be considered. Then also, in addition, some boarding and care facilities, even though they are maintaining pretty well, but sometimes they need to enhance the care to hire more STEM members, including, for example, they probably need some skilled nursing kind of a care, but they were not able to hire a nursing staff due to they don't have actually the additional funding. So we are going to assess all those kind of factors, and then so to evenly actually fairly provide funding to the all eligible boarding and care facilities.
That's great. If there's a report that's being prepared in order to capture all of that, it would be helpful to provide that also to us. Not a special report just for the commission, but if there is that sort of data,
Absolutely. So, yeah.
organize it and provide it. Yeah, thank you.
Yeah.
Thank you. Any further questions? No, I think the follow-up would be important because this is sort of a different kind of venture, and it could certainly be very helpful. It sounds like it could be for organizations that really could be at this point then encouraged to stay in business.
Yes.
Rather than just leaving the city. So at the appropriate times, it'd be important to try to see what's happening in the right, in one of our right committees.
Yes, sir.
Okay.
Got it. No.
That's assuming that we will recommend this to the commission. So we need a motion.
So move.
Second.
All those in favor?
Aye.
Aye.
All right, thank
Thank you.
you. Commissioners,
Thank you very much.
I need your help. We have about 25 minutes, and we have the charity care report. Would you like the presentation to be presented to you that was in your packet, or just to begin discussing the item?
Is there an abbreviated presentation that could just
I'm not
give
sure.
an overview and then we could ask questions?
Well, I mean, the only presentation is what's there, but you could choose slides.
I could try and be a little quicker.
And I'm sorry, Miranda, for this. It's just, we're trying to
We
keep.
try to do
understand.
this in
It's a
about
busy day.
5 minutes.
Okay, I'll do my
In the
best.
PowerPoint so we can have some discussion.
Okay.
Sure.
And I think we've all been able to see the great material that you've sent. So
Thank you.
I think we go over this quickly,
Mhm.
then the rest of the public and ourselves can be re-reminded.
Great.
5 minutes.
Okay.
Okay.
Then we'll go to.
Maybe just start with the findings.
Yeah, I was gonna say,
Yeah,
maybe
that's what I
skip
was
the
gonna
tree and all
say.
that.
Yeah.
Yeah, the
How about like
background. you don't need to
slide
find.
6?
Do you need any background for the public?
Well,
I
I
read
mean, the
it.
historical background, I think most of us already know, and you
Yeah.
were suggesting starting at what, 6?
Yeah,
Um,
slide 6.
Yes,
so-
slide 6.
Perfect. Yeah, I think that, thanks,
Good
Mark.
point.
Sure.
So slide 6 is the overall key findings from the 2022 to 2024 Charity Care Report, which is what the draft of which is what you're considering today. The first of those findings is that the total number of charity care patients in the city increased substantially over compared to the previous reporting period, which was 2020 to 2021. The second key finding was that while uninsured patients continue to need and access charity care, the vast majority of San Francisco charity care patients, 88% in 2024, had some form of health coverage, either through public or private insurance or through Healthy San Francisco. And lastly, we continue to observe that charity care patients across San Francisco hospitals are primarily San Francisco residents. I believe 71% in 2024, and are from groups most likely to experience health inequities. These are, I think we can go through this. These are just showing charts of unduplicated patients and patients by different types of services, and the takeaway is that they have increased. And this is showing patients broken down by hospital. So at most hospitals, the number of patients have also increased compared to the prior reporting period. This is expenditures during for the last 5 years. It's charity care expenditures along the bottom, and then also Medi-Cal shortfall, which is the difference between hospitals' expenditures for services for Medi-Cal patients and reimbursement received from Medi-Cal for those services. And it's not charity care, but hospitals typically absorb this cost, and it's another measure of the hospital's financial commitments to serving low-income patients. And the next slide is showing patients on the left and expenditures on the right over the entire reporting period. So that's 2001 to 2024. And we added this slide at Commissioner Chow's request. A big takeaway is just seeing the impact of the ACA implementation around 2014.
Sorry, can you speak up a little bit?
Oh, yeah, sorry. The impact of ACA implementation around 2014. You can see that charity care patients dropped quite a bit, and that charity care expenditures also, and Medi-Cal shortfall increased around that time.
And so commissioners prepare for that going up again as the changes in Medicaid take effect in the year.
This slide is showing charity care costs to net patient revenue ratio. So it includes each hospital, their net patient revenue, and then their charity care costs, and then the ratio of charity care costs to net patient revenue. So a higher ratio would indicate a higher charity care expenditures to net patient revenue. And the cells highlighted in green are above the state average, which is on the right for that for 2024. And then if you go to the next slide, Mark, this is that same data, but over the entire reporting period, which we also added at Commissioner Chow's request. So you can see over time what that has looked like. The green cells are higher than the state average for that year. And so these are some of the changes that likely impacted charity care during this reporting period. There were 2 new state laws that went into effect that expanded eligibility for financial assistance and strengthened patient notification requirements. And hospitals reported that this contributed to higher numbers of patients and expenditures. And at the federal level, the No Surprises Act, which also became effective in January 2022, limited balance billing for patients for certain out-of-network services, and hospitals with fewer health plan contracts like CSFG reported that also increased, led them to absorb more unreimbursed costs as charity care. And finally, compared to the prior reporting period, which encompassed the COVID-19 pandemic and resulted in decreased utilization, which some hospitals reported was reflected in decreased provision of charity care. In this post-COVID, there's been a rebound in hospital utilization and increase among the reporting hospitals, so that likely also contributed to increased charity care provision. let's see. This is our second finding. So this is around coverage for our charity care patients. The takeaway here is that coverage is quite high. 88% of charity care patients had some form of health coverage, up from 84% in 2021. You can see the way that Healthy San Francisco coverage has decreased as Medi-Cal coverage expansions went into effect during the reporting period in May 2022 and January 2024, and that Medi-Cal coverage increased quite a lot. And then this slide shows some of the demographic data of like who are charity care patients in San Francisco. As has been the case in previous years, they're primarily San Francisco residents with 71% in 2024. In 2024, 12% of charity care patients were homeless or had unknown residents, which is similar to past years as well. And then the map on the left shows that greater concentrations of patients reside in Southeast neighborhoods in districts 10, 9, 11, and in districts 5 and 6, which include lower income neighborhoods. And then on the right, charity care patients are disproportionately Black, African American, and Hispanic Latinx compared with the city's overall population. So this is charity care moving forward. I mean, as you know, there are a number of major state and federal policy changes on the horizon that we expect, the expected impact of which is increased charity care due to increased uninsurance. And that's it. I'll take your questions.
You should get a standing ovation. Thank you so much. I did give Miranda a heads up that she may need to do a version of this. So thank you again for your work. It's very important. And the going through it quickly doesn't mean it's not important, but they didn't need to go.
She stayed within the time limit.
You did. You did a great job.
Now, Commissioners, up to you. So please ask
I'm
questions.
going to only ask one question. Mine, the discussion was already answered about the applications. I'm not
Yes.
going there.
Okay.
Slide 11, when you have got two huge hospitals, CPMC and UCSF, with their average, the percentage of that disparity is, I mean, I'm quite surprised, particularly by UCSF. Is there discussion with them, with these two hospitals particularly, to say you're not meeting the average?
Well, we have the question about UCSF has certainly come up in past years. I think some of the things that they've discussed is that they see a lot of Medi-Cal patients, and their Medi-Cal shortfall is quite one of the highest in the city, and that the aim of their charity care program is to move uninsured or truly self-pay patients into Medi-Cal, and that the charity care program is largely covering people who are underinsured. And so that's leading to and they also, and I would probably need to get more detail about this to be able to fully explain it well, but their faculty practice organization is included in their net patient revenue. And they feel that if it wasn't, that would reflect their ratio at a higher ratio.
Okay, so basically what you're saying is they're uninsured patients with their counting as charity care?
From what I understand, their charity care program is largely serving underinsured patients who are having difficulty with co-pays and things like that.
Because that would be interesting to me, because I had a previous understanding at CPMC that it was for those that did not have insurance.
Oh, I see. This is for UCSF. For CPMC, I'd have to get more information from them. I don't.
Okay,
I don't
but
have
for
an answer for you there. Yeah,
UCSF, it's different.
this is what they've told us. Yeah.
Okay.
There's somebody in the back that wanted to.
Oh, no, no. Yeah, let's wait till I'm sorry. I apologize.
I don't know if she was answering the question. Is that somebody?
no, she's
Oh,
not.
No.
okay. Oh, sorry. Go ahead.
No.
Are you done?
So
At the moment.
just to clarify, so the other hospitals, St. Francis and St. Mary's, they have an overwhelming Medi-Cal population as well. And so I'm just wondering what's the difference between what they're able to do with like an 80% Medi-Cal population compared to UCSF.
Mhm.
So is that calculation different because of the physician practice, the thing that you,
I should get more information so I can explain.
because it's
It will.
something, I mean, we
That's-
should,
And
we should have a discussion around
Yeah.
this, and it's an important piece around their charity care obligation, especially given their affiliation with the county UCSF's affiliation.
It would really be helpful because, for example, I know at UCSF for behavioral health, they do not accept Medi-Cal patients. So
Yeah.
is this part of what they're saying? So I just think maybe more specific
absolutely.
information
Yeah.
on those two institutions
Yeah, absolutely. I'll
would
go
really
back-
be
get back to
super
you.
helpful.
Yeah, can we get something back and just in terms of what discussions are happening or
Yes.
what accountability
Mhm.
opportunities and process there is? Yeah.
Yes.
Yeah.
Sounds good.
Just to even send it to Mark, who will
Okay.
forward it to us.
Well, it's also, this is going to be presented to the full commission at your
Right,
next
this is
meeting.
actually going to be presented to the.
Yeah.
Oh, okay.
commission.
Yeah.
Maybe then.
In
I
March,
think
yeah.
that-
Okay.
that,
I'm sorry, at the March
Perfect.
16th meeting.
Yeah.
Yeah.
It may also be helpful that those questions could be answered even by hospital personnel,
Mhm.
so that it isn't just only on your burden, but
Yeah.
that it would be nice. First of all, it's nice that they are reporting, because this is not part of the regulation. And matter of fact, we will lose more. And it'll be only center in Chinese that will be under the Band-Aid. But we'd like
UCSF
to-
will report they have confirmed they will report for St. Francis and St. Mary's.
For the-
moving ahead. Just-
Well,
guess.
you've confirmed they're going to report separately on St. Mary's and St. Francis, which is really great.
Yes.
And we have to continue to hold CPMC to the same thing, separating out the Vanis campus. Well, they combine Vanis and Davies. And more importantly, separately St. Luke's, so
Yeah.
that we make sure that those those vulnerable areas that we are actually not losing. I would actually like, if you would consider it that as your presentation of the slide 11,
Mhm.
I'd do the one that's the full historical background.
Okay.
Because it isn't
Take
just
that.
this year's number that's important, but coming across
Yeah.
all the 20 years
Okay.
that we've
That's in
had.
this.
And I
Yeah.
think it's going to be more important. Part of this focus, as I think we present this, is to, again, remind us what we will actually be able to know from this report, so valuable that we didn't think we were going to have to do in the future, which is with the decrease of Medi-Cal patients, with the increase in our uninsured, what's going to be this impact
Mhm.
and which facilities are able to really handle it, and what the challenges may be. It's somewhat different from the beginning of this, which of course began historically with why nonprofits were tax exempt.
Mhm.
But I think this is a more important focus, which is what the entire milieu is, and how are we handling those who are in greatest needs but don't have the resources, whether it be under Medi-Cal, ACA, which will also be showing changes,
Yes.
along with the increase of charity care,
Mhm.
and for us to see how the entire city, which is really wonderful for the hospitals that really that are cooperating, we can see how we are then handling this new environment in terms of seeing, and Healthy San Francisco, of course, which is being followed here and we thought would disappear, will
Yeah.
certainly be one piece of that. So I think that we can frame the future of what this report can show. That would be, it isn't just bills on the table, but what we should be looking for, so that we can get the most out of what I think has become even a more valuable report for the future.
Yeah.
Just one other point in terms of the purchase of St. Mary's and St. Francis by UCSF. And so the agreements that they're supposed to be held to as per that purchase. We want to make sure that the charity care percentage, particularly given the the cuts in Medicaid, are not going to somehow reverse the charity care versus Medi-Cal percentages to the detriment of those that have been receiving their care at those hospitals.
So I think to encourage perhaps some of our hospital representatives may really feel inclined to be able to come during the presentation to tell us what their challenges are in the coming future.
Yes, we will absolutely invite them.
We're not here to judge. We're here to work together with the data and try to understand issues that some of our individual organizations may be facing also. So really do appreciate your very fine work.
Thank you.
And how it's going to really be helping us inform the future.
All right. Thank you so much.
Great.
Yeah.
Are there any other questions?
And so actually, we didn't call public comment on this item. It looks like there is a public comment. Would you like to come up and make public comment?
Oh,
And I apologize for, because we're kind of hurried for time, but you take you've got 3 minutes and please do what you need to do.
First of all, I actually did want to piggyback on what she was saying.
Can you speak a little louder?
Yes, I did want to piggyback on what she's saying with the charity care. A part of the reason why UCSF, and this is just based on observation.
Would you like to identify yourself so that we can understand the context of your comment?
Sure. My name is Jessica. I'm an RN consultant / expert witness. I used to be a regulator as well. I've, worked as a nurse clinically. But a part of the reason what she's saying about, UCSF, I just wanted to piggyback on that. A part of the reason why there's not as much charity care that is being done, this is again based on interview, is that one, there's been some hiring, there's been people who have been fired. And so there's less providers. The other thing is when you go to the hospital or receive outpatient services, some of the patients have reported that they're not being informed of this charity care, which, could be, a big part of the reason. For example, like sometimes when they're receiving physical therapy or some of these outpatient services are not being informed. And then when they're in the hospital, there are times where the social worker is, referring them to services, but they're not exactly covering the insurance portion. They're often stating, not often, but there are times where the social worker, especially if they're new, is saying, follow this up with their billing or talk to the other department to hear about patient care services. The problem is that they've already received services from the hospital or, the other outpatients, so they're not really sure of what their charges are. So they're not really sure about what kind of care that they qualify for. But this is just talking about SF Gen. I live in District 10, and a big part of why we're having a difficult time receiving services is because we often have buses where you can't get one direct bus to SF Gen. You got to take multiple buses, and it really hurts my community's ability to receive charity care. So I'm hoping that, there's some type of improved access to this type of care, considering we are probably the heaviest in population that's supposed to be receiving charity care.
Thank you very much.
Thank you.
All right.
Thank you very much. Those were very helpful comments.
We can move on. Is it okay to move on? Thank you, everyone, by the way, for the brevity and the quickness of your comments. 8 is emerging issues. Item 8, hearing none. Any public comment on emerging issues? We're just
Well, I
finishing.
just had one, it's not emerging, but I want to just remind our committee that as soon as we get back into a more regular routine, we need to take up the discussion on how we would like to look at. And we had a number of things we were expecting the department to bring back to us as soon as all this budget fuss is over.
Yes.
And not to lose the fact that what we do want to look at possible contract
Changes.
efficiencies.
Yes, yes, sir. It is on the agenda now and it will continue to be on the agenda, but yes, I will add that. And we can move on to a consideration for adjournment.
Is there a motion?
Second.
All those in favor?
Aye.
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 Thank you all so much.